name's Ledia. I work for an organisation called ThinkPlace, which was established in Australia 10 years ago. But I'm based for them in Nairobi, and today I'd like to talk to you about design thinking and its role in the creation of public value. And I'll use an example from both Australia and Kenya. So here goes. I think the first point I want to make is that rarely do we have all the data that we need to solve problems, complex problems in our world today, especially for things that are multifaceted, things like how you manage a pandemic or how you address substance abuse in society. And to me, issues like this are where we can use design thinking quite a lot. Because to me, design thinking is a way of looking at the world where we can embrace uncertainty and ambiguity. And what you see on the screen here is the design squiggle by Damien Newman. It's usually how I feel at the beginning of any of our projects. Confused, overwhelmed, really disorganized. Should probably not be telling you all that. But I think what Damien Newman was trying to represent with his squiggle, the design squiggle, was to say that design does not try to draw out conclusions too early. It rather tolerates ambiguity, it tolerates conflicts, it tolerates different versions of the truth, as much as we don't like to admit it. And that's because reality is complex. And in my role with ThinkPlace, my job is to help our clients navigate through that complexity. We navigate through the squiggle, we learn together, we innovate together, we experiment together. And hopefully if we do that well, then we can arrive at a really powerful intervention. An intervention in the health system or the social services system or even the law and order system. And yes, design can be used for a whole bunch of different things, including public systems. So this Professor Richard Buchanan, who was, I think, the Dean of the Design School at Carnegie Mellon University in the US, back in the 90s coined this as the 4 orders of design. And he talked about how design can be applied to a lot of different challenges. I think we're all familiar with visual design and graphic design, which is, I guess, the design of signs and symbols. And that's what he called first order design. He then talked about industrial design being the second order, where the focus is on form and function. He then talked about the advent of interaction design or service design, especially with the internet skyrocketing about 20 years ago and human-computer interaction really taking off. And then he said that his argument was that design can be applied to even more complex things than that. And we're talking about whole systems, environmental systems, social systems, and economic systems. And what I'd like to do today is talk a bit more about this 4th order design, the system level thinking. And I guess the solution to a 4th order problem can involve many different things. One example I'll use today is around how it can change the behavior of millions of people if we do it well. Or it can change perhaps a societal outcome by bringing and integrating a whole bunch of different forms of knowledge and experiences together through co-creation. So allow me to take you to where we applied design thinking for a 4th order problem very recently. And that's in Kenya, where 3/4 of the population is uninsured and they have to pay for their health services out of pocket. Now, the National Hospital Insurance Fund, the NHIF in Kenya, is the provider of the Social Health Insurance Fund and has been assigned by the government to achieve universal health coverage. That's very affordable and quality health coverage for every single Kenyan. What this means for the NHIF is that they need to grow their membership base from 2 million, as it stands today, to 24 million within 2 years. That's their political mandate. Now, for salaried employees in Kenya, being an NHIF member or contributor is compulsory, and your employer takes that money from your pay every month. Excuse me. But for the 80% of the working population that is informally employed, that contribution is voluntary. And as you can imagine, that coverage for that 80% is extremely low, and it's been low for many, many years. So we've been working with the NHIF to try to find out why people are not joining, and then when they are, why they're dropping off. To do that, we spoke to 102 people. We'd spent no less than 2 hours with each one of those people. And we spoke to current members, potential members, former members. We spoke to people in the NHIF senior management at HQ. We spoke to branch level staff in rural branches. We spoke to the accredited healthcare facilities that were, doing the service provision of the healthcare that people were signing up for. And we learnt a lot of things. So I'll just share with you a few of those things. We learnt that faith in the hospital system in Kenya, the public health system, I should say, in Kenya, was extremely low. People had witnessed others, and we heard this on several occasions, die before them, 3 or 4 people dying before them, while they waited for a doctor in a doctor's waiting room for just to get care. We learnt that some members experience discrimination. So these are paying NHIF contributors who would go to get their services at health facilities, but then the facilities would favour the cash-paying payments. And the facilities told us this themselves, that they can't stand NHIF's claims processes, and the reimbursements to get their money was a nightmare. So obviously they're only human, they said, and they're not going to really care about people who are going to cause them a headache. They told us, some people told us that the payments that they tried to make over the mobile platform was just not working. And this came up a few times. People were paying through the mobile, and they'd pay month, and then they'll need to access care. So they'll go into a hospital, and then the hospital will say, well, you're not registered, you haven't been making your payments. And we heard this quite a lot. We also saw that the branch level staff are sitting behind really fancy desks in really fancy branch offices in major towns, waiting. And we realised they're going to be waiting a while for people to come knocking on their doors. We also realised that the English-only registration form can be really intimidating. Although most Kenyans can understand English, this was a real turn-off for a lot of them. And we also learnt that there were a lot of private sector options that were way more competitive than what the government was offering, but the government refused to see that way. So I hope you get an idea of the kind of complexity that we were dealing with. And what we did learn by going out to the field, we probably could not have learned through traditional statistical data. It's not the kind of thing you can induct from graphs and tables. So how do you design in this environment? I guess for us, it was about humanizing it. Any health system as a whole has thousands of parts that work together in some way, whether good or bad. These parts can be things like laws, practice guidelines, technologies, organisations, roles, information, and trying to understand how all of these come together can be really challenging if we try to do that all at once. So then we try to humanise this complexity. And I know this sounds really vague and jargony, so I'm going to try to point a camera at it and show you how we try to do that. The first thing we did was we really focused on the user, and we asked them a lot of questions that will help us understand what drives them and what differentiates them. We created personas to help the NHIF senior management team understand that 24 million people can't be all the same. And the way you approach Teresa, the bottom there, who can afford to pay for your service but is not willing to pay because she thinks your service is lousy, is very different to the way you would approach Samuel, who is dying to join your service and thinks it's the best thing possible but cannot afford to pay. So we heard the managers tell us that this really helped them understand their members as people and not as data, and I think this is a recurring theme today. But it doesn't stop there. I think personas is a really great way to understand people. How about if we took that a step further and we tried to understand their experiences. At the end of the day, no one actually experiences the whole system, any system. We experience our own pathway through that system. And that pathway is shaped by all those numerous products and services and touch points which come together to create an experience, whether good or bad. So, we had some people that we met whose barrier was that they just heard bad things about NHIF. We heard other people who said that they couldn't find the information, others who said that they couldn't afford it. We had people saying that they had a really bad experience interacting with NHIF, and others saying that they really just couldn't stand the service they were getting at the health facilities. One story that comes to mind on this, we met a lady, and I'll call her Janice. She went to hospital one day because of her son. He was quite ill, and she had been religiously paying for years. Unfortunately, like I mentioned before, the IT system at the hospital didn't register that she had been making these payments via her mobile. Despite showing the receipts over SMS, she was still turned away. So she tried calling the contact centre, and they told her that she had to come into the head office. So the next day she woke up quite early and she made the 3-hour commute to Nairobi to only have to wait in line for 2 hours after that before she could see someone at the counter. And the person behind the counter told her that she had to write a letter of complaint. And then that she'll have to wait for a response by mail. Meanwhile, Janice's son is still needing treatment and she's having to pay for that out of pocket. So it's a pretty big deal when a public system lets you down. It's much bigger than if you try to buy a book on Amazon and that doesn't go wrong, or if you're trying to order food and that doesn't go right. I think the consequences are much greater than that, because it does mean that someone can make a choice not to participate in a potential system or service or offering that could benefit them and their family later on. So, how could Janice's experience be avoided? I think personally as a designer, I push for this. We need to make the experience as important as the system itself. An example I'd like to show here, and there's a lot of words on the screen, I'm not expecting anyone to read them all, but when we really tried to understand the NHIF system and people's pathways through it, what was working, what was not working, what was good, what was crappy, and there were loads of these stories that we mapped, and we turned them into journey maps like this. And we find that this is really helpful because I guess we can now identify the barriers and ask ourselves, okay, well, what's the kind of experience that we do want people to have? What can we imagine? And then we can work backwards from there and make the changes within the system to help us achieve that. I'm going to take a deep dive now. I'm sorry, this is really depressing. This is another sad story. But if you read just what's in the circle there, this is Teresa's story. And her barrier was that she had a miscarriage in January. The treatment she got at the hospital was appalling. While she was bleeding, they made me go back by myself to a private facility for scans as their machine was broken. Then I had to pay a lot with money that I did not have. I was told I would be refunded, but I wasn't. It was lucky that my friend was there to help me, otherwise I would have died waiting for NHIF to help me. And this was huge for the managers to hear and see. These types of stories really helped the managers see through the eyes of the user. So where are we at now with that project? We've co-developed with the managers at branch level and HQ 17 concepts to improve the experience of the informal sector in finding out and in experiencing NHIF. Now, this is sitting at the board, and I don't know what will happen. Maybe some will go through, some will not. And the other thing which I think is really exciting is that we've been asked to help them develop their annual work plans. So that's 120 managers that we'll be working with to develop their annual work plans based on, I guess, a place of empathy and some of the things that we found out. So I think that's really exciting because we start looking at design's role within an organisation and that sort of cultural shift and change and its role in change management. I think that's really exciting for us. So my next point is about empathy, and I can't emphasise this enough, emphasise the empathy. I'm not sure if there are many Australians in the room, I can pinpoint one, but there was a show that was made in Australia a few years ago called Go Back to Where You Came From. I highly recommend it. It was a four-part series where they got a bunch of, maybe a handful, 5 or 6 Australians that were racist-leaning, and they put them through a bit of a 1-month exercise. And they started by throwing them into a rural immigration detention centre in Australia for a few days, and they just had to find their way. And then they threw them on a boat coming from Indonesia that was a bit shabby, and it was in the middle of a storm, and they had to risk their lives, and they had to survive that. And then they threw them in some refugee camp. I think there was some in Syria and some in Kenya. And the transformation, that journey that people were able to experience and that we all got to witness was pretty tremendous, because their worldview changed in a matter of weeks in a way that would not have been possible if they were sitting, reading the paper, sipping on their coffee, in the sun by their swimming pool in their backyard. It just would not have happened. And I think this really emphasises the point about putting ourselves in people's shoes and empathising with the lived experiences of people to help us make these decisions that affect them. So, I'm running out of time, so I'm going to try to get through this other thing. So on the Australia note, let's go to Australia. For the next example, I'm going to read out some numbers. 320,000 people is the number of people living with dementia in Australia, and this number is estimated to increase to 1 million by 2050. So the government last year allocated an extra $200 million in funding for research on prevention, diagnosis, treatment and care. They asked us to help prioritise the allocation of funding to ensure that society gets a really good return on investment. Now, the issue of dementia is quite a complex one because it sits at the intersection of the global scientific system, scientific research system, the healthcare system, and the aged care provision system. And none of these systems fully account for the problems faced by people with dementia. So how do we bring the experience of people living with dementia into the national priority setting agenda? Well, we talk to them, their families, their caregivers, doctors and researchers for multiple perspectives. And I just want to share with you some of the things we heard. We heard people say, we find it easier and cheaper to medicate people and sedate them than to manage them in a behavioural model. There is a disconnect between the funding and the promotion of independence. You are rewarded for the less a person can do. The sicker they are, the better. We are so risk avoidant that we are taking away their dignity and autonomy. And if staff enable a resident to do something for themselves, they get a serve because they are not following the care plan. Immediately after the diagnosis, people stopped talking directly to him. They didn't know how to engage. This is the last one. I'm really the same person I was right after diagnosis, but I'm not treated that way. So, some of you may already know, with dementia, there are behavioural symptoms associated with it. People wander, they get lost, they get confused, and sometimes they can even get violent. And this gets tough for them, but also for the people around them. There is a tendency to over-medicate and over-sedate to deal with this. It keeps people calm, sitting in a chair and all drugged up. But if that person decides to stand, they might feel a bit disoriented and they might even fall. So their independence is reduced. And if you have dementia, this current model of care is just the opposite of the kind of care that you actually need. But when we told researchers this, they told us, so what? We already knew that. The real problem then, we came to find out together, is actually in the translation space. So the question became, how do we get over this translation barrier? And I think it's come up a few times today about bringing voices together to build a shared vision for change, and that's what we did. We brought in, all the people that we had been speaking to, caregivers, families, researchers, medical practitioners, to be able to do that. So this is the 4 voices of design, and I'm just going to quickly go through this. I think it's really important to have the right voices in the room when you're doing co-design and when you're trying to build this shared vision for change. The voice of intent is the one that sets the direction. It exercises authority and it takes accountability for decision making. The voice of experience is focused on sort of desirability. It's based on the real and practical experiences of citizens, clients and staff. And then you've got the voice of expertise, which has sort of that expert knowledge about what is possible and viable, policymakers, legal people, tech people, ops people. And there comes in the voice of design, which brokers and synthesizes all these voices to ensure that each one is heard in the right amount. So I think for us on this project, the result was a process of authentic engagement, one that built community trust in government and shared accountability among stakeholders, because we were able to get a balanced perspective from all of these 4 voices. I do also want to say that it didn't come without its challenges. We were working with researchers who had spent the best part of their life, 30 to 40 years even, looking at the synapses of the brain through microscopes and dissecting mice and spending a lot of time in labs. And then there was us trying to get them to use sticky notes and, do designerly stuff. And it was not easy. And I think one idea that we really did, manage to get through quite well was this idea of iteration and a prototyping mindset. And we did insist that we have to get this wrong several times before we get it right. And I think by the end of it, everyone was extremely happy with it because we had gone out and tested it with other people who were not just in the core working group, to test a lot of the ideas and assumptions we were making about this new priority framework. Now, the last thing I want to do, one more thing actually, the value. $200 million spent now could have saved billions of dollars down the track, and you've got sort of a quick snapshot of the priority framework that we developed. And the last thing I want to do is introduce you to 2 people who I met a few years back. First person's George, and George has a tendency to fear uncertainty, avoid new experiences, and he has quite a narrow repertoire because of that. And then there's Jeff, who accepts uncertainty, seeks new experiences, and has a broad repertoire. And I guess the question I have for you all today is, who do you want to be making the decisions that affect you? This is not mine. This is definitely from Jean Litka, and I recommend that you look her up because she's amazing. Because she talks about George really focusing on understanding customers or citizens as data, and Jeff really understanding customers as people. And I think for me, this is a very clear decision to make, so I'll leave it all to you to decide who you would like to be making decisions that affect you. Thank you.